We've been having a series of discussion on neuroanatomy, and today we want to talk about the most underrated, literally underrated part of the brain, the brainstem. It might look just like a small part, but trust me, it has got a lot of functioning when it comes to the functions of the brain. What's up, ladies and gentlemen? Welcome back to Neurosketch with Dr. Ken. But this is the first time you've seen this channel, don't forget to subscribe. Welcome to the series of discussion on the brainstem, and the brainstem is so broad that we have a lot of different videos that are going to help us to have a solid understanding on the brainstem. So for this discussion, we're going to talk about the surface anatomy of the brainstem, but be sure to follow the subsequent sessions where we're going to discuss about the internal anatomy of the brainstem. We talk about the overview of cranial nerves. We talk about each cranial nerve individually. We talk about the brainstem reflexes. We talk about the consciousness system, and of course talk about the disorders of consciousness like brain death, coma, and some other disorders of the consciousness. Yeah, this discussion is meant for the surface anatomy of the brainstem, and as usual, let's go back to square one. We said we have four major parts of the brain. We have midbrain, pons, and medulla that are forming the brainstem. And just behind the brainstem, we have the cerebellum, which is translated to the little brain. And on top of the midbrain, we have diencephalon, which is made up of thalamus, hypothalamus, and epithalamus. And of course, on top of the diencephalon, we have the biggest part of the brain, which is called cerebrum. Okay, so the brainstem is our topic of discussion today, and the word brainstem is like the stem of the brain. Remember, this is a tree, and the tree has got a stem. What is the function of the stem of the tree? Yeah, is to connect the upper part of the tree and the roots. Yeah, it anchors the upper part of the tree to the roots, and of course it also transmits materials between the roots and the upper part of the tree. Same applies. This is the brainstem. One among the obvious functions of the brainstem is to transmit information between the higher parts of the brain and the spinal cord, and of course between different parts of the brain. There is no way that information is going to come from the spinal cord to the upper part of the brain without passing through the brainstem. I understand nowadays we're living in the world of wireless connection, but the brain is so primitive that it relies on wire connection. Yeah, so the information has to pass through the brainstem to get to upper parts of the body of the brain, and of course from the brain, upper part of the brain, to the spinal cord through the brainstem. Yeah, so there is no wiring connection, and the brainstem acts as a corridor in that sense. So is that the only function of the brainstem? No, excuse your brainstem. The brainstem is not a simple channel. It has got a nucleus of its own. It has got nuclei that are helping it to perform its different activities. For example, the brainstem has got nuclei for 10 out of 12 pairs of the cranial nerves. You have 12 pairs of cranial nerves, and 10 of them, they have the nuclei deep within the brainstem. Remember, we said nuclei, correction of neuronal cell bodies within the central nervous system. Now, these cranial nerves, they have their cell bodies deep within the brainstem. So the brainstem is taking care of the function of cranial nerve number 3 to cranial nerve number 12. From cranial nerve number 3 to number 12, they have the nuclei deep within the brainstem. But the brainstem also has got nuclei that is that you are controlling the level of consciousness. You are this conscious right now just because of the brainstem. You can always thank your brainstem when you are conscious, but the brainstem has got nuclei that are controlling the respiratory activities, breathing in, breathing out. The brainstem has got nuclei that are controlling the cardiovascular activities, pumping of the heart and the stuff. Has got connection with the cerebellum, which is called the cerebral circuitry. Has got nuclei that are dealing with the muscle tone and of course posture. So in a simple words, the brainstem is the unsung hero of the brain. It does a lot of this vital functioning, and the credits are going to the cerebrum, the biggest part of the brain. Listen, the brainstem is the one that controls the respiratory and the cardiovascular system, which in my opinion, these are the most exhausting system of the body. Remember, ever since you were born, your respiratory and the cardiovascular system have been operating every single second of your life. Every single second of your life, the respiratory and the cardiovascular system have been operating. And who is the mastermind behind it? The brainstem. Yeah, but you see, the cerebrum at times it goes to sleep, at times it takes nap, but the brainstem never takes nap, because this is the one that controls the respiratory and the cardiovascular system, which are operating every single second of your life. Then look how small the brainstem is. The brainstem is so small and yet does all these functions. That means these functions have been compacted within a small brainstem. So even a single region in the brainstem, it can result into substantial deficit. Unlike the biggest part of the brain, for example, if you have damage here, it might not result into substantial deficit because you have a lot of other functional areas of the brain, but the brainstem is so small, and even a small part of the brainstem is crucial for different activities, because the brainstem itself is small, has got a number of functions, and so every part of the brainstem is crucial. Injury, even a small injury, can result into substantial deficit. Now the brainstem is sitting in the posterior cranial fossa together with cerebellum and occipital lobe. What are the main parts of the brainstem? One more time, you have the midbrain, pons, and medulla. And I will say the midbrain is superiorly bordered by the diencephalon, but to be specific, the thalamus. And so this junction is called the midbrain diencephalic junction, the junction between the midbrain and the encephalon. And the inferior, I will say it, the medulla is bordered by the spinal cord, but to be specific, the cervical part of the spinal cord. Remember, spinal cord has got different parts, yeah? So the cervical part of the spinal cord. And so this junction is called the cervical medullary junction, a junction between the cervical part of the spinal cord and the medulla. And this junction is exactly at the level of the foramen magnum. Remember, we said the foramen, we said the medulla is in continuation with the spinal cord. And so what marks the demarcation between the two is the level of the foramen magnum. Above the foramen magnum, it is medulla, but below the foramen magnum, it is the spinal cord. So also have junction between different parts of the brainstem. For example, a junction between the midbrain and the pons, it is called the pontomesencephalic junction, because mesencephalic from the mesencephalon. Remember, the midbrain is coming from the mesencephalon. So this junction is called the pontomesencephalic junction. But also have a junction between the pons and medulla. This is easy, pontomedullary junction, a junction between pons and medulla. Yeah, so these are the surface features of different views of the brainstem. This is the ventral view, this is the dorsal view, and of course this is the lateral view. Yeah, so this is how it looks like on the ventral view, and this is the dorsal view, this is the lateral view. What I want you to pay much attention is the thalamus is not a part of the brainstem. Of course, it's here, but it's not a part of the brainstem. Yeah, thalamus is not a part of brainstem. As you can guess, it is coming from the diencephalon, and our brainstem is starting from the midbrain, pons, and the medulla. Midbrain, pons, and the medulla. You can excuse my lines. This line should have passed it here, but because of imperfections, it's here, but it should be passing here. So this is the medulla. Of course, this is the midbrain, pons, and medulla. And of course, this downstairs here, this is the spinal cord, and they will say this spinal cord is happening at the level below the level of the foramen magnum. Okay, now we're going to discuss each part in turn, starting with the midbrain, and this is the dorsal view of the midbrain. And the posterior surface of the midbrain is called tectum, which means roof. So this is literally the roof of the midbrain. The posterior surface of the midbrain has got 4 rounded elevations, 2 of which are superior and 2 of which are inferior, and they are called colliculi for plural. In singular is colliculus. So we have 2 superior colliculi and 2 inferior colliculi. This is singular. Of course, we have 2 on inferior, but I've just pointed one. This is singular for colliculi. Singular is colliculus, plural is colliculi. 2 superior colliculi, 2 inferior colliculi. Yeah, and together, because these are rounded elevations, 4 rounded elevations together, they are called corpora quadrigemina. Corpora for bodies, because it's coming from corpus. Corpus is singular, corpora plural, and quadrigemina means 4. We have 4 bodies, 2 superior, 2 inferior. And the superior collicula is easy because the superior collicula is dealing with the visual activities. It is with things like visual spatial attention. We're going to talk about these stuffs at some point, but it's also dealing with eye movement, especially saccadic eye movement or saccades. We're going to talk also about this at some point, but it's also dealing with the accommodation reflex and head movement. Easy. Superior colliculi for vision. Yeah, vision. It deals with the visual activities. Inferior colliculi, on the other hand, they are dealing with auditory information, relaying the auditory impulse from the ear to the thalamus. But one among the most fascinating function of the inferior colliculi is the so-called the stator reflex or the moral reflex. This is the involuntary protective motor response that is triggered by sudden change in the body balance or the intense sensory stimulation. 2 important things that may trigger the motor reflex or the so-called the stator reflex. Number 1 is the sudden change in the body balance. Number 2 is the very intense sensory stimulation. So, for example, when you hear a very loud sound, for example, gunfire, that kind of reflex, that kind of reaction that you're getting is called the stator reflex. But also, when you have the sudden change in the body balance, that kind of reaction that you're getting is also called the stator reflex, which is also called the motor reflex. I have an example. Number one, seeing the response to very intense sensory stimulation. Let's see this cat over here responding to a very intense sensory stimulation, and we see, okay. You see, so that kind of reaction to intense sensory stimulation is the motor reflex. It's a reflex, yeah. It does not decide to do so. It does it automatically, okay? Also have another response to sudden change in the body balance. And actually in pediatric, in newborns, we usually do this test, which is called the motor reflex, and they will tell you this is one among the most important brainstem reflexes in newborn. Yeah, it should be there. So let's see how the baby respond to the sudden release and sudden dropping of the baby. How does he respond? So you see, this is meant to be protective. Yeah, the baby is protecting himself. You see, in Israel we say kujihami. Yeah, you see how he stretches the arm. Yeah, you remember, what are you doing, bro? Yeah, that's protective, and it's called the moral reflex. And don't do this if you are doing it for the first time and you are not under supervision. It might cause injury to the baby. All right, so these are the corpora quadrigemina. One more time, we have two superior auriculae and two inferior auriculae. The superior auriculae that are dealing with the visual, pathways, and the inferior auriculae that are taking part in auditory pathway, and on top of that, they're doing that stator reflex. We also have some other structures that are connecting to the superior auricula and the inferior auricula. For example, to superior auricula, you have the so-called the lateral geniculate body, and the lateral geniculate body is connecting to the superior auriculae on either side. So we have lateral geniculate body on this side and lateral geniculate body on this side that are connecting to the superior auriculae, and so they are also taking part in the visual pathway. We're going to see later on the visual pathway. You can always trace that discussion. But also have the medial geniculate body or medial geniculate nuclei, which are connecting to the inferior auricula, and so they are also helping in mediating the auditory information. So whatever has been done by the inferior auricula is also been done by the medial geniculate bodies on the other side, and the superior geniculate by the lateral geniculate body. But between the two superior auricula, you have the so-called the pineal gland. Pineal gland is also called the epiphysis cerebri, and this is very, very important because it releases an important hormone, which is called the melatonin. Melatonin is also called the sleep hormone. This is what determines when you are going to sleep. In other words, the melatonin is controlling the circadian cycle, which is also called the sleep-wake cycle. When you go to sleep in the evening, you wake up in the morning, is because of this melatonin, which is released by the pineal gland. Circadian cycle is literally referred as an internal clock because this is what makes you sleep in the night and wake up in the morning. If you usually go to sleep at 10 p.m., for example, if it reaches 10 p.m., even if you don't have a watch, this cycle will make you fall asleep, and you tell you know what, bro, it is time to sleep, and you have to sleep right now. And if you usually wake up at 6 or 7 a.m. in the morning, if it reaches that time, this cycle will also make sure you wake up. And for that reason, this cycle is also referred as an internal clock, and this is how it has been designed to operate. Of course, it's been controlled by melatonin, and the melatonin is affected by a number of factors, and literally anything that can affect melatonin, it can result into disruption of sleep cycle. Yeah, things like light, for example. You see some people tell you, I find it hard for me to fall asleep when the light is on, because the light switches off melatonin, and the melatonin is what controls sleep cycle. Yeah, things like energy drinks, for example, they will also disrupt the sleep cycle. Of course, we'll have a separate discussion on the sleep cycle, the circadian cycle, and we'll talk a lot of details when we reach there. Also, on the posterior surface of the midbrain, we have a pair of cranial nerve, which is cranial nerve number 4, trochlear nerve, and this is the only nerve which is coming off dorsally. All other nerves are exiting either ventrally or ventrolaterally, with an exception of cranial nerve number 4, which is coming from the posterior surface of the brainstem. Of course, it's one among the two nerves that are coming from the midbrain. The midbrain is associated with the two cranial nerves, which is cranial nerve number 3 and number 4, and the cranial nerve number 4 is the only nerve which is coming from the dorsal surface of the brainstem. Not only the midbrain, the whole of the brainstem. This is the only nerve which is coming posteriorly. Okay, let's now see the anterior surface of the midbrain. And anteriorly, the midbrain has got two bump-like elevations, which are called cerebral peduncles, one on the left, one on the right. They are cerebral peduncle, not cerebellar peduncle. Of course, we will see later we'll have cerebellar peduncle, but these are the cerebral peduncles. And the word peduncle means pedal, yeah, foot, appendages or foot. And these are the structures that are supporting the brain and are called the cerebral peduncles. Of course, they are part of the midbrain, and we later see that they are formed by white matter bundles that are forming the corticospinal, corticobulbar, and the corticopontine tracts. We discussed them when we were doing the motor pathway. Between the two cerebral peduncles, we have the a fossa which is called the interpeduncular fossa. Inter means between, interpeduncular fossa. And as I've told you, the midbrain is associated with only two cranial nerves, which is cranial nerve number 3 and number 4. And the cranial nerve number 4 is the only nerve which is exiting the brainstem dorsal, is coming from posterior. All other cranial nerves will either come ventrally or ventrolaterally, with the exception of trochlear nerve, which is cranial nerve number 4, which is coming from the posterior surface of the midbrain. Now, also we have some other structures which are not part of the midbrain, but they are adjacent to midbrain. For example, the optic nerve, optic chiasm, and the optic tract. We discussed them when we are doing the anatomy of the visual pathway. But we have something like mammillary body, which itself is not a part of the midbrain, but it's a part of the encephalon, and is taking part in the limbic system. And to be specific, it's dealing with it's primarily dealing with recollective memory. In fact, all these structures in lead, they are not part of the midbrain. Now into the next part, let's discuss about the pons. And the word pons means bridge. This region over here is what is called bridge, which is usually 2.5 centimeter long. It is a bridge, but it is not a simple bridge because it has got nuclei of its own that are doing different activities. We're going to see this nuclei when we are doing the internal anatomy of the pons. But on the surface anatomy, we see the pons has got a groove which is called the basilar groove, and this basilar groove is usually occupied by the basilar artery. We're going to discuss them later. The basilar artery. Now, the pons is associated with the cranial nerve number 5, which is called trigeminal nerve, number 6, which is abducens nerve, number 7, which is the facial nerve, and number 8, which is the vestibulocochlear nerve. But I want to make something very clear here, that the trigeminal nerve is the only nerve that emerges from the pons proper. These other nerves that emerge in between the pons and the medulla, the junction between pons and the medulla. And so, yes, they are associated with pons, but they are not coming from the pons proper. They are not originating from the pons proper. Yeah. So, cranial nerve number 6, 7, and 8, they emerge from at the pontomedullary junction, a junction between pons and medulla. Let's go to the posterior surface of the pons. This is what we see on the posterior surface of the pons. We have 3 cerebellar peduncles. Now these are the cerebellar peduncle, not cerebral. And these are peduncles like feet, feet. So these are the feet of the cerebellum. So this is how the cerebellum is attached to the brainstem, because the cerebellum is like the backpack of the brainstem. It's like the brainstem has put the backpack, and it's been attached to the brainstem by the way of these cerebellar peduncles, where you have superior cerebellar peduncle, middle cerebellar peduncle, and the inferior cerebellar peduncle. Also on the dorsal surface of the pons, you have 2 elevations which are called the facial colliculi, and these are nothing but how the motor fibers of 7 are looping around the nucleus of 6. The motor fibers of cranial nerve number 7, they are looping around the nucleus of cranial nerve number 6, which is abducens nucleus. The motor fibers of 7 looping around the nucleus of 6, they are producing these elevations on either side. And we're going to see later on the internal anatomy how they are looping around, but they are producing this, the facial colliculi. Okay, into the last part of the brainstem, medulla or medulla oblongata, which is usually 3 centimeter long. And 3 centimeters is a very short distance. That means a lot of these functions have been compacted within this small distance. That also means even a small region in medulla can result into substantial deficit. And don't forget, a lot of these vital functions like cardiac and respiratory are also within medulla. So even a small region in medulla can be fat, right? Can result into death. So the medulla is starting at the level of the foramen magnum proximal, going upward. Remember, the level of the foramen magnum is where we have the cervicomedullary junction. So between the cervicomedullary junction and the pontomedullary junction is where we have medulla. And one among the remarkable surface features of medulla is the presence of pyramids. We have 2 pyramids, one on the left, one on the right, and these 2 pyramids are made of white matter bundles that are carrying information from the higher centers of the brain to the lower part of the central nervous system. They are carrying motor fibers. We're going to discuss them later. But one among the important thing to notice here is that at the lower border of medulla, we have crossing over fibers. The fibers that are within the right pyramid, they are crossing over. 90% of these fibers are crossing over to the opposite side. Why is this important? This is important because this is the one that determines the contralaterality. Remember, we said if you have damage on the right side of the brain, you have weakness on the left side of the body. If you have the damage on the left side of the brain, you have weakness on the right side of the body. Why weakness on the right side of the body? Is because of the pyramidal decussation, and this is, in simple terms, the pyramidal decussation will help in the contralateral effect. Another remarkable surface feature of medulla is the presence of inferior olive. You have 2, one on either side, and these are taking part in the olivocerebellar system, where they're helping in timing and learning of motor activities, motor skills, and coordination. Let's talk about the nerves that are originating from the medulla, and ideally the last 4 cranial nerves are taking their origin from the medulla. That is glossopharyngeal nerve through hypoglossal nerve. They have their origin from medulla, and we see all these nerves are originating ventrolaterally, on the ventral side, on the ventrolateral surface of medulla. So this is cranial nerve number 9, which is glossopharyngeal nerve. This is cranial nerve number 10, which is the vagus nerve, originating from the ventral surface of medulla. And then we have cranial nerve number 11, which is the spinal accessory nerve. And remember, the spinal accessory nerve has got double origin. Part of it is coming from the spinal cord. You can see part of it is coming from the spinal cord. It has got roots that are coming from the spinal cord, and they are ascending. They are going through the foramen magnum. They are entering the cranial cavity. They are going to join the parts that are originating from medulla. They are forming a single nerve, which is called the spinal accessory nerve, which has got 2 roots, the spinal root and the cranial root. And this single nerve which is formed is going to exit the cranial cavity through the jugular foramen as a single nerve, going to supply, of course, this trapezius and the sternocleidomastoid muscle on the ipsilateral side. That is cranial nerve number 11. You should always remember that it has got the double origin, and of course sometimes this is matter of controversial. Some people say state the otherwise. Okay, so and next you have the hypoglossal nerve, which is cranial nerve number 12. And the cranial nerve number 12 is coming between the pyramid and inferior olive. Remember, this is olive, this is pyramid. In between is where the hypoglossal nerve originates. The hypoglossal nerve exits the medulla on the ventral surface or ventrolateral surface between the olive and pyramid, and this region is called that sulcus is called the pre-olivary sulcus, because it's before you reach to the inferior olive. This is medulla. This is the sulcus between them. This is the pyramid. This is the inferior olive, and then you have a sulcus which is called the pre-olivary sulcus. A sulcus before you go to the olive. Here is where the cranial nerve number 12 exiting. This is where it exits the medulla. Okay, so the nerve which is exiting between the pyramid and inferior olive, that is the cranial nerve number 12. On the posterior surface of medulla, we see you have the hypoglossal trigone, which marks the nucleus of 12. You have the vagal trigone, which marks the dorsal motor nucleus of 10. and we're going to see them when we're doing the internal anatomy, the cross section of the medulla. But also the posterior surface will have an opening here, entrance to the central canal of the spinal cord, which is called an obex. As I've said, an obex is the entrance. It marks an entrance to the central canal of the spinal cord, and it is not the same as the foramen of Magendie. This over here is called the foramen of Magendie, and the foramen of Magendie is how the cerebrospinal fluid is leaving the ventricular system to go to the subarachnoid space. But an obex here, it marks an entrance to the central canal of the spinal cord. They are different, and you should not confuse them. In exam. And then of course we have nucleus cunatus and the nucleus gracilis. These are the sensory relay nuclei. They are relaying information, especially in the dorsal column medial lemniscus pathway. We're going to see the sensory pathway, especially DSML, which is dorsal column medial lemniscus. The information are being relayed within these two nuclei, the nucleus cunatus and nucleus gracilis, and of course they're being connected by the fasciculus cunatus and the fasciculus gracilis respectively. You will understand that, you will notice that because you have foramen magnum here, the nucleus cunatus and the nucleus gracilis, they are found in the medulla, but the fasciculus cunatus and the gracilis, they are within the spinal cord. So they are getting this information, they are going to synapse to the nucleus, to these two nuclei, which are relaying this information that is coming from dorsal column medial lemniscus pathway. We have said that the medulla is in conjunction with the spinal cord. That means they've got a lot of things in common, but they also have a lot of differences from one another, and you should be able to tell these differences because at the time they might ask you in exam the difference between spinal cord and medulla, and I've recruited some for you here. Okay, so the key external features, if they ask you what are the key external features between the medulla and the spinal cord, you should say the presence of olive and pyramids. We have clearly seen that pyramid and olive, they are found within the medulla and they are absent in the spinal cord. But the key internal differences, we discussed about the orientation of white matter. I told you the other time that in the brain, the white matter is inside, the gray matter is outside, but that's quite the opposite in the spinal cord, because in the spinal cord, the white matter is outside and the gray matter is inside. And this is key internal anatomy, the differences between the medulla and the spinal cord. But you can also talk about other things like the shape. For example, you see the medulla is a little bit like conical shaped, and the spinal cord is more of a cylinder. But also you can talk about the cunatus tubercle and the gracilis tubercle that are prominent in the medulla and they're not seen in the spinal cord. Of course, you have these fasciculus, which are not as prominent as these tubercles that can be seen from medulla and spinal cord. But if you ask to name in exam, if you use this one, these are the most recognizable and most accepted differences between the two. I have some questions for you here, so be sure to write, to read it clearly and put your responses. And this is a spot kind of exam. This is what they might ask you in exam, like practical exam. Name the identified structure I and J, and name the clinical significance of J. So be sure to put your thoughts there. So this is what I had for you, and if you've enjoyed this discussion, don't forget to like and share with your friends. But if you have question, additional comment, put your thoughts in the comment sections. And if this is the first time you're seeing this channel, don't forget to subscribe, and see you really soon. Ciao.